everybody, and welcome to the Personalized Lifestyle Pearls. I'm Dr. Deanna Minich, and today we have a special guest. We always have amazing guests. Every 2 weeks, we are now doing the PLPs. And this time around, we have Dr. Kara Fitzgerald. Kara is a naturopathic physician on the East Coast of the United States. She's in Connecticut. And she does a lot of different things. She teaches, she writes, she sees patients, and so kind of a whirlwind of activity. And so the topic that we're going to be talking about today is one that really applies to just about everybody tuning in, and everybody we know, and it's that of inflammation and its role in chronic disease. So welcome, Kara. Glad to have you here.
It's always awesome to get to hang out with you, Deanna. Cyberspace or in person. I know, and I'll see you in person in the not so distant future. But anyway, yeah, it's always great.
And I just want to let everybody know I am having a little bit of Wi-Fi issues. I think you can hear me okay. You may not see me clearly. But anyway, let's dive right in. Kara, maybe you can talk with us a little bit about what is inflammation? We hear a lot about it, but how do we actually define it?
Oh, that's so funny. That's a really broad question. Let's do a little bit of drill down around inflammation. I mean, it's your immune system. It's your immune system turned on and responding. I mean, it's just, first of all, if you think it's complex, it's logarithmically more complex, and it's always unfolding. We're still discovering specialized white blood cells. Isn't that amazing? Like, we just discovered Th17, and there's and the various cytokines produced and what it does in the body, et cetera, et cetera. I mean, it's extraordinary, the complexity of the immune system and how it's unfolding. So the immune system is engaging in protecting us, defining whether what we're exposed to is healthy or not healthy, reacting to what we're ingesting, reacting to the compounds, reacting to our connection. In fact, I was just thinking about, kind of funny, you and I always have a good time talking, and that's kind of an anti-inflammatory activity, kind of brings down the stress response, and it's fun, right? Because we like talking to each other. But anyway, so it's our immune system sort of reacting to the inputs. And of course, when we've got a negative input, like if I'm exposed to a pathogen, if I go out for sushi and I'm exposed to a pathogen, my immune system is going to, most of the time kind of kick in. Or if I'm exposed to my daughter's cold, my immune system is going to kick in. And ideally just kind of knock that infectious agent out, gobble it up, break it down, get rid of it, and I get on with my life, and I don't even know that I was exposed to something. So that's what's happening all of the time. What we're talking about, Deanna, and our topic today is this whole idea of chronic inflammation, when the immune system's turned on, or, it's so complex. Again, we can have an arm of the immune system actually suppressed and not doing its job, and another arm, overly responsive and responsive to self versus, so the response is imbalanced. And it's this area that I would argue is most of what we're quenching and attempting to balance in our work as functional medicine providers. What do you think?
That really gets us off to a good start. Thanks, Kara. When I think medically of inflammation, to me what comes to mind too is rubor, color, dolor, tumor.
Yes, that's right.
Yeah. Redness.
Yep. Cardinal signs. Yep.
Just having edema. But then I think what we're seeing is that there can be this meta-inflammation, kind of like increased TNF-alpha, increased IL-6, increased HSCRP. So maybe talk about some of the labs. Like if somebody were to go in and say, doctor, am I inflamed? Do I have inflammation? What might be some of the laboratory biomarkers, and maybe some of the obvious physical symptoms? Because maybe we don't have redness, pain, swelling, or
at least not visibly. Not visibly. I think the cardinal signs of inflammation.
There it is.
Yeah, for sure. Yeah, like we could have arterial signs of inflammation, and we're not able to actually see them. So what would my basic workup be for patients? Somebody coming through my door. So in functional medicine, we're going to cast a little bit of a wider net, but primarily if you go to your regular doc, they're going to run a CBC. So we're going to look at our white blood cells, and we'll look at the individual white blood cell types, and we'll see if there's an imbalance there. And incidentally, Deanna, one of the best, easiest, most affordable markers is just seeing a little spike in total white blood cell count. It doesn't have to be, it can be within normal limits, just on the higher side. And that's actually strongly correlative with inflammation, or it is inflammation. So that's an easy thing to think about.
I'm kind of curious, before you go on from white blood cells, what if somebody has a low white blood cell count? Do we need to be concerned about inflammation in those people?
You know, yeah, we would absolutely still be considering inflammation. So a normal white blood cell count, or an actual frankly low, like a leukopenia. What do you ask? Either?
Yeah, just the total WBC.
Okay. If your white blood cell count is within is a healthy normal limits white blood cell count, yes, you can absolutely have inflammation going on elsewhere. So you can't stop your investigation at white blood cells, but I think, you know, as something to consider when you see something trending up, and when you see white blood cell count trending up in patients, you can think about that. And then of course you can look at the different types of white blood cells, and you'll get an idea, like if eosinophils are really high, we're going to be thinking about most classically allergic disease or parasites and so forth, and infection with neutrophils and so forth, viral with lymphocytes. And then we would do a CRP, an HS-CRP, which you mentioned. We can do a SED rate. And those are like probably our big workhorse conventional inflammatory investigations.
What about acids? Wouldn't you order a fatty acid panel, omega-3 index, to see if somebody has an imbalance there?
Yeah. So then when we move into the functional medicine world, we're going to be casting a much wider, broader net. We can look at, of course, some of the inflammatory markers associated with cardiovascular disease, such as, you know, LP, phospholipase A2. That's a good one. Or myeloperoxidase is another good one. Or fibrinogen, looking at viscosity, blood viscosity is a great one. Yeah, looking at the omega-3, omega-6 ratio, seeing what's going on with arachidonic acid specifically. Is it very high relative to EPA and DHA? Yeah, no question about it. Those are incredibly useful. And one of the cool things about all of those that I've just mentioned, you can get them often covered by insurance through the standard reference labs. Like, we don't always have to ask for our patients to pay out of pocket for those that I've mentioned. They're so much more available than they used to be. One of my favorite fatty acid derivative, F2-isoprostane, you can get through both of our, the most famous standard reference labs. And it's a good, arguably best marker of lipid peroxidation, which is inflammation right there at the lipid membrane.
Good. And what about like a 64 fatty acid panel? Do you think that that's necessary, or should we really just aim for something simple, low-hanging fruit, omega-3 index?
Yeah. So I love the full.
I know what you would prefer.
I love it. I think it's really cool to look at, and we can fine tune and get information there. But you're exactly right. The low hanging fruit is where it's at. We want to have people achieve a good omega-3 index. I mean, the science behind it is just so cool. We want to make sure that omega-3s are just robustly represented in the lipid membranes in all of our cells. And then we want to make sure that omega-6s aren't too high. Yeah, you can do those basic panels, get them insurance covered, send your patients to the standard reference lab. You don't even have to draw in your office if you don't do that. And yes, exactly, start there. And then when you get to a certain level of complexity, or if you're not getting the outcome that you're expecting, then you can get the full panel.
Yeah, I want to come back to that, but we do have a question from Robert, who is from Utah. Thanks for your question, Robert. And by the way, for everybody that's signed on, I see a number of you here, some of you I know. Feel free to be asking questions, and so we can get Kara to answer those. He's asking, what about just even basal body temperature, and looking at, if one of the hallmarks of inflammation is too much heat, would we be assessing anything by measuring temperature, is what he's asking?
Yeah, I think that could be useful. That could be really compelling. And, in classic conditions like, mono or perhaps a refractory Epstein-Barr reactivation of Epstein-Barr, you might, spike an afternoon fever a little bit. Often, though, in our patients for whom their immune system is out of whack, you'll see a lower basal body temperature. So you might have them do serial measurements over different time points in the day and see what you find. But certainly that's a classic finding in hypothyroidism. And if you've got Hashimoto thyroiditis, you're going to be hypothyroid. You're going to have a low body temperature. So a normal or a low body temperature does not rule out inflammation at all. That could be diagnostic as well.
Let's talk about metabolic endotoxemia. So when you mention kind of flu or allergies, when we eat, it's kind of the inflammation that can happen in the gut if we have dysbiosis.
Yeah.
Can we measure endotoxin, which is a marker of inflammation, inflammation? Can you talk a little bit about that?
Yeah, so we can. So specialty labs can measure, you can get LPS, you can get LPS antibodies. And I think that's predominantly how you can get it fairly routinely. There's specialty labs, but you can measure antibodies to LPS. And if those are very high, it suggests that LPS is elevated, that endotoxemia is happening. Most clinicians practicing functional medicine are going to assume endotoxemia with most of their patients presenting with chronic inflammation. And especially, really, we're seeing intestinal permeability is really kind of de rigueur. Anybody coming to us with autoimmunity, or if we diagnose autoimmunity, intestinal permeability appears to be part of the pathogenesis of that condition. And if you've got intestinal permeability to any extent, endotoxemia is going to be following that because it's happening because of the increased permeability. So I think we just need to assume it's there, Deanna, and address it. Do our full functional approach, obviously tend to the gut. Most of us are getting stool samples. Most of us are looking at diet. We're looking at reactions to different foods. We're cleaning up the dysbiosis. We're patching the leaky gut. We're doing all of those interventions. And in that journey, LPS should be brought into control. One of the other really cool little snippets of science that I know you're aware of is that LPS binds to toll-like receptors, but especially 4, which sits in the lipid raft and in blood cell membranes and turns on all sorts of nefarious intracellular activity like NF-kappa B and just all of the whole cytokine cascade. So LPS binding toll-like receptor 4 right there in the lipid membrane. However, if you have a good omega-3 index, like if you shift the ratio of 6 and 3s in the lipid membrane, you are going to change the binding affinity of that LPS to the toll-like receptor and change the downstream actions. It's pretty amazing. So that's just one of the many pleiotropic effects of omega-3s, and we could actually spend some time talking about that. So just making sure you've got adequate omega-3s is going to impact the reaction of endotoxemia, and that's just through that mechanism. And there's a zillion other ways that we can actually go after it.
Kara, let us circle back to omega-3s, because I think one of the things that has happened is that there's a lot of awareness in certain circles of medicine around omega-3s. And so many people are supplementing. What I have seen in practice is that even with high supplementation levels, that people's percentage, their absolute EPA and DHA percent, is still hovering at around 4 to 5. So then it leads me to think, are they not absorbing it? Are they excreting it? Are they using it? And then on the other hand, we can also throw our omega-6, omega-3 balance out of whack. Aren't there some anti-inflammatory omega-6 fats too? So I'm just kind of curious, what are your guidelines for therapeutic supplementation of omega-3s? How do you discern how much? How do you enable optimal absorption through bile acids, which they're emulsifiers? So maybe talk about just omega-3 supplementation in general.
Yeah. Okay. There are some pretty neat studies looking at the differences in absorption. Not everyone absorbs equally, and that's so that's a fabulous reason why we can grab omega-3s and 6 through a standard lab and get our index and make sure we're dialing it in, and we can do multiple, tests and get coverage. So it's fabulous. It's easy. Yeah, we all don't absorb equally. And yes, we definitely have to be thinking about gut health and about bile acids. And we can, of course, supplement with those if need be in our patients to optimize absorption. And then you can think about, different forms of omega-3 fatty acids to see if the triglyceride form appears to be much more bioavailable. However, the other forms, the esterified, the ethyl ester forms are may not be quite as bioavailable, but if you can get prescription, if you can get coverage for them, so my bottom line is that the triglyceride form probably most bioavailable, but if you have the ethyl esters, if your physician has given you a prescription, continue with those and just track absorption. And of course, doing the gut work. If you're working with a functional medicine provider, you're going to do all of those pieces to make sure that you're absorbing and hitting what you need to be hitting. Additionally, Deanna, this as nutritionist extraordinaire, it's an uphill battle if you're eating a lousy diet. If you're eating an omega-6 intense diet, you're going to have a really hard time dialing your omega-3s in. So that's one thing that we have to change. It's up to 25-1 omega-6 to omega-3s that we're ingesting in consuming a standard American diet. So we need to adjust that. The other piece is that when we're on that metabolic continuum, higher blood sugar, higher insulin, those both of those promote the production of the desaturase enzymes, which basically take omega-6s, linoleic acid, and shunt it down to arachidonic acid. So when we're consuming lots of sugars, lots of simple carbs, expect that you're going to see more of the pro-inflammatory omega-6s being produced, and that's going to throw off your ratio. So just consuming an anti-inflammatory diet is going to help.
Yeah. We do have a question here about krill and algal oils. And I want to tag on to that. What about vegans that don't want to take the fish oil? Talk about the conversion of ALA, the kind of the mother precursor omega-3, into longer chain anti-inflammatory fats. So talk about what are options for vegans, your thoughts on krill and algal DHA.
Okay, so krill, I loved krill. I was like, when krill made the big splash here, I just transitioned a whole bunch of patients onto it. I was pretty excited about the possibility. I became a little anxious around stealing all, the food from whales. It just, as far as the ecology of it, I got a little bit anxious. And the other thing is that it's very expensive. Yeah. And if you want a dose to actually see a better omega-3 index, so some of those workhorse markers that we know are important because there's so much research on them, I didn't see bear out with krill. The science around krill has been limited to cardiovascular stuff, like looking at, God, what are the main krill studies? It's been, I have to say,
PMS that I remember too, but you're right. The amounts of omega-3s are so
super expensive.
Small,
yeah.
But you do get astaxanthin and a lot of these different carotenoids that may benefit the activity and bioactivity of the different fats too. So that's kind of the neat aspect of krill, I think.
Yes, you're absolutely right. So I think the price for krill, the amount that you need to take, just makes it prohibitive for my practice.
Yeah, absolutely.
I think we can achieve these outcomes that we're talking about, using our workhorse sustainable fish oil sources. If we want to kind of layer a little krill in for some of those amazing flavonoids that you just mentioned, we could consider that. But by and large, I'm sticking with fish oil. I think it's the best. But yeah, if you're a vegan, so this is pretty interesting. Some of us can really efficiently shunt alpha-linolenic down to DHA and EPA, and some of us don't. Premenopausal women actually seem to be doing a better job, and that's speculated because the fetus needs it. So so premenopausal with our various hormones around, we might actually do a better job at making it. However, we don't know. I mean, there are mutations actually in these desaturases that would limit us. I would say that you absolutely want to use flax, you want to use chia. In fact, even if you're taking fish oil, we should be incorporating those nutrient dense seeds into our patient's diet. But if you're only using those, or if you're using algae, which can be helpful as well, you just need to get the omega-3s. You need to be leaning on tests and making sure your patient's doing well. You also, again, want to make sure that they're not, if they've got a higher insulin or sugar, they're going to, their omega-6, their arachidonic acid production is just going to be so much greater as to kind of dwarf the omega-3 status. So in your vegan patients, we can do a great job. You just have to pay attention.
Yeah. And what about the anti-inflammatory omega-6? Omega-6 gets such a bad rap.
Yeah.
GLA and borage oil and evening primrose oil. Is there a place for them?
People like GLA. Yeah, definitely. I think it's only a matter of time. Like if I were, you and I have talked about this, I would completely be, I do a PhD in lipidology if I were going to go back again. And I would really focus on DGLA, dihomogamma-linolenic acid, which is why we take GLA. So it's an omega-6 that has these anti-inflammatory eicosanoids. We're going to talk about SPMs in a minute. And if I were a betting woman, I would be putting money that DGLA makes some really cool SPMs, but we also know that it makes anti-inflammatory eicosanoids. So yes, there's definitely a place for these, Deanna. And the thing is, though, if you take GLA alone from borage or EPO or however, you're giving substrate to convert to arachidonic acid. So it's an omega-6, and it actually occurs in the metabolic, or in the synthetic pathway before arachidonic. So some of that GLA will absolutely be converted to arachidonic unless you give EPA. Chilton has shown conclusively time and again that if you give EPA with your GLA, you will inhibit the conversion, and it doesn't take a ton of EPA. So you've got somebody on a basic, EPA, DHA, fish oil, and then you use GLA as indicated, you'll inhibit the conversion to arachidonic. It really doesn't take much. And yeah, Deanna, I'm with you. I think there's good evidence, not great evidence, but good evidence for GLA. I think if our researchers always accompanied GLA with EPA, so it didn't convert to arachidonic, the GLA research would be much more robust.
I almost feel like all our viewers need some kind of pathway chart to see all these acronyms, right? And it can really be Googled. You can get the essential fatty acid elongation and desaturation pathway, which Kara and I are referring to here. Let me ask you this, Kara, because I get this question a lot. It's kind of like if you have a hammer, everything looks like a nail. So is there a limit to how much omega-3 that we should be taking? Are there situations where we're taking too much? I remember, for example, that I tested my levels some time ago, and I was supplementing with an oil-based omega-3, a high concentrate one, and I got up to 12% as my omega-3 index, right? And most Americans are at 4%. Japanese people tend to be about 8%, and 8% is kind of that cardiovascular mark. But what if we go so high?
Yeah.
We keep supplementing. Is that so good? And what might be some contraindications to that?
That's a great question, and there is some literature around it. And let's not forget to talk about SPMs and
we will.
Some of those derivative compounds. Okay. Having too much. Well, first of all, listen, we vilify arachidonic acid, but it's like it's a very first arm player in our immune response. And you want, if you're exposed to that viral pathogen, you're exposed to a bacteria, you're exposed to whatever in life, you want some arachidonic acid derived eicosanoids to get in there and get busy and do their work. It's when they're inappropriately launched that it becomes a problem. So we don't want to unnecessarily suppress arachidonic and the associated eicosanoids. We want that first line reaction. It's when it's and we're going to talk about SPMs, and of course, you know, these are the specialized pro-resolving lipid mediators, and these guys. So we've got our eicosanoids turned on via arachidonic acid. We've got the inflammation cascade happening. We need it because there's some sort of there's a process going on that requires the immune system. But then, and this is an acute inflammation I'm talking about, you guys, but then we need to have the SPMs around to actually quench it. And it takes, amazingly enough, it takes the pro-inflammatory to turn on the anti-inflammatory. It's a symphony. So in acute, just to have a good immune system, we need some arachidonic. We don't want to insufficiently we don't want to over suppress it for the long term. However, in our chronic inflammation patients, you know, when I talk about this at IFM, when I'm lecturing on this particular topic, in chronically inflamed patients, we see arachidonic acid routinely extremely high. And for those folks in the early treatment phase, we absolutely want to drop it down and raise omega-3s up. So in the beginning months of the journey, I dose my omega-3 fatty acids at least at 2,500 milligrams, sometimes up to 5,000 milligrams, depending on what's going on. So early in the journey in a chronically inflamed patient, I get in there very aggressively with my omega-3s and drop the arachidonic. But then along the way, you know, we balance out.
Mm-hmm. Mm-hmm. So let's get into SPMs in our remaining minutes. What does SPM stand for? What are we referring to when we're talking about SPMs? If we can kind of whittle into some of the details, and how do we use these therapeutically? What is it? Is it a supplement? Kind of get into that.
They're really, really exciting, honestly. So specialized pro-resolving lipid mediators, or I just call them resolvins or SPMs. You're familiar with eicosanoids. You know, we're familiar with the eicosanoid family. There's hundreds of these guys coming from arachidonic and EPA and so forth. There's, and they're involved in turning the immune system on. Like, lipidology is no joke. These polyunsaturated fatty acids, they're just really complex. So we know the eicosanoids. Well, it turns out there's all sorts of other derivative compounds that are made from our fatty acids, and exquisitely important are these resolvins or these SPMs. These guys are involved in cleaning up inflammation. So eicosanoids turn the party on, get the party started, and then SPMs come in and quench it. If you don't have enough omega-3s, you're not going to harness those SPMs, and those are so essential. So we can think about chronic inflammation as a failure of resolution. Most of us do not have adequate omega-3s, and therefore we don't have these cleanup SPMs around to turn off the inflammatory process. And that's a big problem. Although we do make anti-inflammatory SPMs from arachidonic acid, it's not enough. We need the symphony of SPMs to quench inflammation. So number one, people are dwarfed in omega-6s and we don't have enough. The other thing that's really fascinating, Deanna, is that if we shut down inflammation via medication, most famously aspirin, higher dose aspirin, or non-steroidal anti-inflammatories, ibuprofen, and so forth, if we shut down those COX and LOX enzymes, we will indeed shut down the ability for the body to actually make the SPMs, because it uses those same enzymes. And if we inhibit it, which we always do, you have a little pain, you take some ibuprofen, you know, you bang back some aspirin. If you inhibit those enzymes, if you overly inhibit those enzymes, you'll shut down the ability for resolution.
And I think that answers Robert's question. He just asked, do we create the SPMs? So yeah, we sure. So we have all the right materials. We're able to do that.
Well, what's interesting is that sometimes we don't all make them as efficiently as we could. And eventually we'll be testing SPMs. Believe me, we will be looking, because we make SPMs all over the place in many different tissues for many different purposes. There are SPMs in the brain, the neuroprotectins, you know, they're in the liver, they're in circulation, they're in the muscle tissue. I mean, it's such a cool science. So we want to make sure in our lipid membrane we've got adequate omega-3s so that we can make them. But arguably, acutely, and in my practice, I'm using SPMs early in the journey of my chronically inflamed patients. So these patients come to me and they're in inflammation, they don't have enough omega-3s, they're inhibiting their ability to make the resolvins, and I can actually prescribe SPMs to them. And that's, and I just, you know, I use it all the time. And I actually think it's fair to use them for all of our chronic inflammation patients. I see a lot of allergic disease folks, and you and I were talking earlier about how I've seen some great outcome, you know, acute asthma, and well, it doesn't replace an inhaler, but I think that you can get in there early. And I've seen it, you know, turn it around. What else? While we're doing all of our underlying functional and functional medicine stuff, and while we're getting our lipid membranes, you know, loaded up with our omega-3s, urticaria, autoimmune disease, rheumatoid arthritis, you know, musculoskeletal inflammation of any kind. Using SPMs early on can be extremely helpful.
It's so true. Kara, we're at our end of our session here. So I just want to kind of zoom out because we said a lot. So I'm just wondering, if maybe you can just kind of give a quick summary. So for people that are dealing with inflammation, or for clinicians who have patients with inflammation, what are some of the kind of the first line approaches? Maybe if we can just kind of almost like in a bullet pointed list, like check these things and then think about these things therapeutically as we close. So
we can think, I mentioned a CBC, I mentioned, you know, a SED rate, CRP, what else? We can get the omega-3 index now. We can go to standard reference labs and look at omega-6 and omega-3 actually pretty carefully. We can consider phospholipase A2, myeloperoxidase. We can think of fibrinogen. There's a host of labs that we can get to investigate inflammation in our patients. And then I would say concurrently, early on in the journey, things that are going to influence the omega-3/6 ratio are diet. So you want to go anti-inflammatory in your diet. You want to control, you want to drop insulin and blood sugar and really think about those, because those will increase arachidonic acid production and decrease omega-3 status. And then you want to start on your omega-3s. So you immediately want to begin in there working on that. So start on your big omega-3 fish oils. And then you want to, early on in the journey, I think that there is a place for using resolvins or using SPMs for that early turning around the inflammatory picture quickly and powerfully. Wonderful. Well, I can tell you have a lot of passion for lipids. I come from 4 years of doing my PhD. I know. I can say they are intriguing. You know, not all fats are created equal. They're all very different, and yet we talk about them as one big category of fat. I know. But so thank you for having that appreciation, bringing that out for the viewers, and also talking about the complexity of that from a clinical perspective. So thank you so much for sharing the Let me say one more thing. I know you have to cut me off, but I just want to say, so the SPMs that we're using are actually precursor molecules, and they can be broken down to any number of resolvins. So a host of different activities can happen when you take those precursor compounds. Yeah, absolutely. I always have them on me. So I'm traveling now. My bag of supplements has a bunch of SPMs in it. You just never know. Yeah, you never know. You never know. I mean, and they really, you know, they work pretty quickly. I mean, it's kind of extraordinary. You know, you do an intense workout or whatever you might need them for. I know it's me. Thanks so much, Kara. Always a pleasure talking with you. You too. All right, I'll see you soon. Thanks to all of our viewers, and Robert, Tammy, and everybody who's weighed in. Thank you so much for being on with us. And tune in next time. We're going to have another guest. We just keep bringing in all the experts. So even if you're not on for the call live, don't forget that we always have the recorded talk on the Metagenics Institute page. So thanks so much, everybody. Take care. Bye-bye.